Welcome everyone. We are thankful for your participation today to join us in this important discussion on trust, a precondition for protection and durable solutions. Before we begin, I would like to thank our organizer of this webinar, Center for Asia Pacific Refugee Studies, Asia Pacific Refugee Right Network, and Asia Pacific Network of Refugee, and Asia School of Business. As Abraham Lincoln said, the people, when rightly and fully trusted, will return the trust. Please join me in welcoming our esteemed panelists. Our first speaker, Dr. Melati Nungsari. Dr. Melati is Assistant Professor of Economics at the Asia School of Business and Research Affiliate at MIT Sloan School Management. She is an applied microeconomics specialized in industrial organization, public and labor economics, market design, and economic education. Her research focuses on two-sided, matching platforms with search. Public policy issues such as labor market integration of refugees in Malaysia, policy designed for retirement market in Chile and Malaysia, entrepreneurship amongst low-income population, labor market discrimination, and economic education. Welcome. Our second speaker is Dr. Alina Akhyar. She currently manages multiple portfolios for International Rescue Committee, working as a program implementation and strategic initiatives, specialized senior health coordinator and team lead COVID-19 response in Pakistan. She has been with the IRC for more than 2 years, and before that has served at key and SMT level position in organizations like MOM, GAVI, MSI, USAID, and Nutritional International. Her areas of specialization: systems strengthening, research, advocacy, EPI, nutrition and fortification, maternal and child health care. Welcome. Our final speaker will be Professor Dr. Ahmad Faisal Muhammad Berdaus. Dr. Faisal serves as president of Mercy Malaysia. Professor Faisal Muhammad obtained his Bachelor of Medical Science in 1989 from University Kebangsaan, Malaysia, followed by his master's degree in internal medical in 2000. He was accredited as respiratory physician in 2003. His involvement with Mercy Malaysia began in 2003 when he signed on as a volunteer. He was made a member of Mercy Malaysia Executive Council in the same year. He headed the drug rehabilitation and assistance program in Malaysia from 2003 to 2006. Before being elected as president in 2010, in 2014, he was appointed in the board of trustees of Mercy Malaysia UK, MMUK. Dr. Faisal tours of duty include Sri Lanka, Sudan, Indonesia, Pakistan, Myanmar, Syria, and Philippines. Professor Faisal currently sits on the board of Humanitarian Innovation Fund's Advocacy Training Program on Humanitarian Action and Professional in Humanitarian Assistance and Protection, of which Mercy Malaysia is a member. He became the first Asian to be elected as chairperson of the International Council of Volunteer Agency, ICFA. On the 6th of April 2021, he received honorary PhD in medical science from University Science Islam Malaysia, which granted him the title professor. Congratulations, professor. First, we would like to start it with introduction and slides by Dr. Melati. Dr. Melati, the floor is yours.
Thank you, Omar. So I guess I will be speaking primarily on Malaysia to give a bit of context to everybody on what's happening in Malaysia and what sort of has happened during the pandemic with regards to refugees in this country. And then I'll set the tone a little bit for the topic of our webinar, which is trust. And then I'll sort of go ahead and give it back to Omar. So let's go ahead and start. So I will share my screen really quick. All right, so for those of you who are tuning in, some of you may be familiar with the background on sort of refugee issues in Malaysia, but I thought I'd give a bit of a flavor. So I am based in Malaysia. I'm an economist studying issues related to refugees in this country. And so let me just give you a background on the study that we did regarding COVID and the pandemic and sort of the lived experiences of refugees during this time. So we know that Malaysia has had a very long history of hosting refugees. The data sort of shows us that this dates back to the 1970s with the arrival of the Vietnamese boat people due to displacement out of Vietnam. Currently, Malaysia hosts at least 178,000. I believe the numbers have been updated to around 180,000 from 50 countries. And we actually host the most number of refugees from Myanmar outside of Bangladesh, most of them being Rohingya people. Malaysia, like most Southeast Asian countries, has not signed the 1951 UN Convention on Refugees and its protocol. Therefore, refugees in Malaysia have no legal status. So you may have heard of sort of this extreme precariousness resulting from sort of this lack of legal status. So no access to affordable healthcare, no access to public schooling for children, no legal right to work, no protection, essentially from a legal perspective, sort of a whole host of issues that come with it. Now, specifically, what I will speak about just a little bit is trust. And I will be talking about this study that we did, basically looking at the experiences of refugees during the pandemic in Malaysia. Now, Malaysia is currently battling a very vicious 3rd/4th wave, but this was done sort of at the beginning of the pandemic, meaning mid 2020 or so. And what we collected was basically in-depth, long interviews of 39 refugees. These are both leaders of refugee-based community organizations, but also sort of, average members of different types of Rohingya, Chin, Kachin, a variety of different ethnic groups, which we were able to contact. And I will be showing you just very quickly, a model that we built to sort of understand refugee experiences and then how trust factors in. So this picture right here gives you a bit of a timeline on when this data was collected. So around June was sort of the first round of interviews, and then second round of interviews was September and October. Now, trust. So speaking to the thing that connects all three speakers, I believe, is this very broad idea. And if you look at how academics describe trust, you can find basically 100 different definitions. But in the study, and sort of maybe we can talk a little bit more about what other panelists think about this as well. But how we define trust is going to be the following. So trust is a combination of trusting beliefs, meaning the belief that another person is benevolent, competent, honest, predictable in a given situation, and also trusting intentions, meaning my willingness to depend on somebody else in a situation. So as you can kind of think about, the variety of relationships can sort of be defined by trust, right? So like public health, as we're in the pandemic currently, is strongly reliant on trust, both from the refugees' perspective, as well as the trusting the government to be able to push out vaccines, to give you care when you need healthcare, et cetera. So this is how I'm going to set the stage in terms of what is trust. And I'm not going to go into details, but basically what I found was this experience of the refugee during the pandemic, which basically is the following. So we have, say, policy changes that affect trust, as defined in the previous slide, that then affect the attitudes and compliance with public health measures, with anything related to basically containment or mitigation of the pandemic. And of course, all of this interesting thing is actually mediated by experiences. So how a refugee's experiences during the pandemic affects trust levels. And we see from the data that we collected, that experiences are strongly influenced by identity. So, how you physically appear to people, your personal identity, trauma. So, for example, one quote that we had from our study was that in situations where authorities had to sort of cordon off an area with barbed wire, that often brought up a lot of trauma for a lot of refugees, and therefore caused them to have a negative experience, which then caused them to have a reduction in trust. But we also see sort of good things from some of these relationships, like refugee community behavior, local NGO behavior, sort of positively affecting trust. And the dotted lines here are sort of indirect effects, and the solid lines are what we call direct effects. So we can talk a little bit more about this, but just to set the stage. And then we also in this study spoke of these idea of agents of trust. So the data revealed to us that refugees actually sort of conceptualized people to trust as sort of what we call these agents of trust. These are people who are able to sort of positively affect trust. So if you're sick, these are the people who are able to sort of push you to get seen for a doctor. These are the people who you trust for information, etc. So family members, community, locals. So some Malaysians did play a role in this. Employers providing you correct information on risk, testing, stuff like that. NGOs, so local NGOs who help give food aid. That was a big part of the study, was looking at the distribution of aid. And the UNHCR as well, sort of played a factor again in the dissemination of information. We also found that authorities are a very complex construct for refugees and sort of could be divided into distinct categories, which is very interesting for my last slide next. I'm going to talk about some policy recommendations, but essentially we found that for using the data set, we saw that trust of sort of authorities could be divided into distinct categories. So healthcare workers, civil servants, so when you speak about people at the ministry, politicians, immigration, and police. So these were sort of 5 different categories of authorities that was partitioned by the respondents to our study. And so I'd just like to end here before we jump into the discussion. So why does trust matter? And why are we doing this whole webinar? I'm just speaking as an economist studying these issues. So we know that trust is very well studied in past public health crises as well. There were a bunch of studies looking at sort of trust in health system and vaccine hesitancies during the Ebola outbreak. Trust improves citizen involvement, governmental performance. It can, cause people to do things that are good for the public, such as, paying taxes so that we can enjoy public goods, decisions to report crimes, sort of general trust in the legal system. But I think the crucial thing here is that with hidden vulnerable populations, trust is even more crucial than any of these studies that we've spoken about. And so given the picture I showed just now, the major policy recommendation is basically for local governments, so in Malaysia to work with NGOs and community-based organizations when interfacing with the refugee community, because, and I didn't manage to speak about this very much, but because there was such an erosion in trust. So in Malaysia, we witnessed a lot of detentions, a lot of raids last year that basically affected experiences, if you remember my picture, which then caused sort of a decline in trust, which then means that people are less likely to reach out to comply with orders or rules and stuff like that due to their bad experiences. So given this trust deficit, one major policy recommendation from this study is basically to get people to, governments to basically work with people on the ground in order to sort of reclaim some of that trust, because the amount of trauma and negative experiences has kind of eroded whatever was there. So I guess that's all I have in terms of the slides. Omar.
Thanks a lot, Dr. Melati. May I ask you, can you give a concrete example on how is distrust constructed within the refugee communities?
Yes. So we have, if I can go back to the slides here. So we have a sense in which there's different types of trust, right? But this study specifically was looking at trusting, and if you go back to the definition here, trusting authorities to be predictable in a given situation. And I think because of some policy changes last year in Malaysia, there was a lot of anxiety around that, which then eroded the sense of dependability on different types of authorities. So I think the concept of trust is very multifaceted for everybody, but specifically for refugees, who a lot of our respondents actually reported being very personally attacked by some of the policy changes, which then of course, changed how they believed and changed how they saw the world around them, which then influenced their later behavior in terms of, if you have a sore throat, you get tested, all that kind of stuff. There's also some amount of misinformation and information filtering, but I won't have time to talk about that very much. But that's basically how trust was conceptualized in this.
Thanks, Dr. Melati. And also, other question, why is it important to focus on the element of trust in policies pertaining to refugee issues?
Thank you, Omar. So I think because of the precarity of refugees with regards to not having legal statuses, trust is a huge thing, right? So there's sort of implicit agreements with authorities that you should not be harassed on the streets, that all residents of Malaysia, refugees or not, have access to vaccines, that you should be able to go and access testing if you need it. So all of these sort of amenities and resources during a pandemic, whether or not a refugee accesses them is actually going to depend on trust. Now, I would argue that if you had really bad experiences last year, so for example, some of our respondents reported, friends and family getting deported or getting, put into jail for a long time before they were allowed release. If you had that kind of experience, I would argue that you would probably have a less of a willingness to reach out if you needed any help. And I believe, and perhaps Dr. Faisal can speak a bit to this, but I believe that this will also be an issue with trying to, reach out for vaccines, for recovery later on. A lot of people have lost their jobs, for aid distribution, etc.
Thanks a lot, Dr. Melati, for those amazing points that was shared by you. Now moving to our second speaker, Dr. Alina Akhyar. Given the recognition on the importance of trust, lessons learned from the past include Ebola. Why is there still a lack of action towards building trust among the refugee community?
Thank you so much, Omar, and thank you so much, Dr. Melati, for the very insightful presentation. Probably I'll pick on a few things that you have already shared. As all our attendees who are part of this webinar are aware of the fact that a lot of our focus for today's webinar is on the fact that how do we bring in the element of trust, especially for the vulnerable groups and around refugees. And that not only pertains to Asia, but across the world as well. And most of us, I'd say all of us know that COVID-19 has been a very unprecedented situation, and it has actually compounded the vulnerabilities for the most vulnerable, with refugees at top, the people who are internally displaced, the people who are displaced because of climatic changes, and so forth more. I'll probably reflect on our learnings as International Rescue Committee. Happy to share the white paper which has been recently published that actually talks about on how can we build trust in our communities, that is to have a sustainable role towards COVID-19's immunity and how to combat misinformation. Probably I'll share a few live examples of what we have done as a country program and how we have kind of taken our learning from the Ebola's response as well a few years back. Just to give you a bit of background, because since Dr. Melati has talked in detail of how do we see trust and what indicators are there that kind of feed in and roll out in such an unprecedented situation. So in Pakistan, I think we were hit by COVID back in Feb 2020. First 2 cases were reported in the last week of February. However, immediately the situation kind of escalated. And following the global protocol, we had a national lockdown imposed on 23rd of March. So a first-hand reaction, like any other country of the world, was actually to shut everything down. So by national lockdown, I mean, and most of us are aware of the fact that everything was shut down, including medical OPDs, including labor rooms, including hospitals, because of 2 things. One, people were afraid. There were apprehension that in case if you reach out to a hospital, you might contract COVID, because we were still learning at that point of time. And then another was for the fact, because of that national lockdown, entire set of public transport within city and out of city was actually also shut down. So as I shared earlier, that this actually led to compounding of vulnerabilities for groups, especially for that of refugees. If I'm to talk about the stats for Pakistan at this point of time, and as per a report that was actually published by UNHCR, they have around more than 1.4 million registered Afghan refugees. And you're aware of the fact that we share one side of border with Afghanistan, and there have been movement starting from the end of 1989, post-Russian Revolution, and then proceeding to the events that have taken in the last 2 decades or so. A few of them have returned back home, but you're aware of the fact of the situation, the circumstances, and the security concerns that are there within these 2 borders. And even with the lockdown that I'm talking about, government realized that in order to help support, you can't shut everything down. So we actually learned that then the Torkham border and the Chaman border, the border that we share with the side of Pakistan, was actually opened by the end of April. And then you're aware of the fact that when we open borders, it is very difficult as in to ensure social distancing. So I'm talking in context of how this was kind of very complex in terms of the COVID situation for the last year, and that is what we saw as well. And then people were struggling. I think for people who are the resident for the country, things have been relatively easier, I'll be honest. Reason being that you're registered citizen of the country, you have access to healthcare programming to an extent, you have access to education to an extent as well, especially in the public sector. But if I'm to talk about the refugees, the displaced population, it gets very difficult. Even with the registrations, we actually realized, I think mid last year, that a lot of the refugees who were registered, their cards had expired, and they were also concerned for the fact because they were not actively seeking information, especially for COVID care. And we're aware of the fact that COVID is complex and has been ever more complex. Our learnings, I'll reflect on our learnings. We actually saw that a lot of the refugees and a lot of the vulnerable groups, they preferred staying back in their own settings, in their own refugee camps. Reason being that, one, they thought that maybe they do not have the right to reach out. As Dr. Melati has shared, that trust needs to be a two-way communication. So I think midway last year, we actually realized that we need to start talking to these groups, say it aloud, that we also understand their apprehensions on part of the masses, but they're kind of compounded and aggravated because of the for the refugee population as well. So our immediate what do you call that, immediate knee-jerk, it was not exactly, I wish it could have been a knee-jerk reaction, but then again our followed sustained reaction was actually to engage these groups, reach out, inform them, kind of make that complex information around how to prepare for COVID-19, how to access services, which in these instances are kind of confined to a registration number or a CNAC number. But then again, I think the 4 pillars have actually worked, and I'm happy to share the white paper that actually categorizes them under these 4 pillars. One, as I shared earlier, immediately after the first lockdown, we were the ones, I think ISC was the first one who knocked on the door of the government and the Department of Health, making them realize that you can't shut everything down. This actually makes things difficult for the vulnerable groups. There are people who have resources as in to reach out to the private sector, but then the people, especially that of the refugee groups, instead of waiting for them to reach out to the health facility, let's have a program where we reach out to them, making that information palatable in terms of not only how to safeguard themselves from COVID-19 in those refugee settings, but God forbid, if they have any symptoms, be it moderate and severe, where they can reach out as well to have access to those services. And I think attendees and colleagues who are actually part of the forum, they're aware of the terminology that we actually use: minimal initial support package. A lot of work in Pakistan's country program has been done over the past 7 years, and the foundation of that work was building trust in our community. If I have to talk about for Khyber Pakhtunkhwa province, which has the higher percentage of Afghan refugees in addition to Balochistan, and the idea was that you make healthcare services or emergency services available in such humanitarian crisis. Though nobody had seen COVID prior to that of November or December 2019. But then again, I think having that information and knowledge translated into action was the need of the hour, and that is what we did. It was important to have health services primarily made available for women, for girls, and especially for the vulnerable groups, including that of the refugees. And I think that went well. And a lot of our advocacy in terms of engaging local community influentials, religious leaders, because since a lot of our minimal initial support package was around complex reproductive health areas, so we had done the most difficult part, so it was easier to talk to government and as well as the vulnerable groups around a thematic area similar to that of COVID-19. And then following the triggering of the services around minimal and initial support package, I think what we did was, as Dr. Melati has shared, that we actually started using the already embedded, trusted factors which were there, especially in the Khyber Pakhtunkhwa province. Our immediate reaction was actually to reach out to those trusted individuals, to reach out to those religious leaders who had trust in our work that we had done in the past 10 years. And I think that made the entire difference in the world. Imagine us not being in touch with the communities and we reaching out with a complex set of information that why it is important to maintain social distancing. I think our relationship with them, our trust, and I regard trust as a two-way communication, that I give them that knowledge and then I give them that freedom that they take up that knowledge and translate that into action. And that is what happened. It was not an easy process. We had to convert that complex set of information into palatable set of actions. And then I'd say, learning from this, we actually realized a lot of these refugees might not be able to walk into healthcare centers because of their distances, because of lack of resources, information. And I think IRC was the first one who actually kind of shifted immediately from, instead of vouching for quarantines and isolation facilities at the level of hospitals, we actually started a model around home-based care. So by home-based care means we engage people from within community who are actually well informed from our frontline workers. So your frontline workers need to be well empowered on how to build that trust. So that was, since it was already there, we kind of linked them with the community people and the influentials and the trusted voices, and they were carrying those messages back not only to the vulnerable groups, including TGs, including the refugee population. And we had a lot of our work was around community engagement, actually TGs as well. And then, which is amazing. And they've actually been able to produce the amazing results in terms of informing people, even masses, not just TGs, transgenders, that is what I'm talking about, but then masses as well, that why their vulnerabilities are being compounded because of a COVID-like situation. And then that home-based model made the entire difference. So we made those services available. As you're aware of the fact that a lot of the COVID cases are either initially mild or they're moderate, you can easily manage them at home. That is, if you have the right direction, you have the right medical orientation from the required practitioner. So I think that has actually given us the edge in terms of having that trust in place, relying on that trust in making those services available, and then empowering those vulnerable groups with the required set of information. And then another point that Dr. Melati and Omar might have already reflected upon were around the fact that the need of that two-way of communication. Do not expect that you're bombarding everything in terms of saying that we are giving you everything as to build that trust. Until and unless it is endorsed, it is taken up and not kind of translated into action, the trust is just a factor that is, you're giving an input, but you're not getting an outcome, not even an output. So we have an intervention. I'd like to share an example that Pakistan has actually established a portal, which is by the name of a signpost intervention. And then again, the idea was to make this available and accessible to everyone, especially the vulnerable groups and the refugees. So this is the forum that actually provides toll-free helplines. And there's a digital forum, there's a website that is backed up by clinicians, practitioners, psychologists. So we're aware of the fact that we're living in times, and even in COVID's era and in post-COVID era, we're likely to see issues pertaining to mental health. So mental health can be kind of, there are many indicators that we're currently seeing in terms of stress, in terms of psychological first aid. Imagine, God forbid, if there's a refugee, if there's a vulnerable individual and they can't move out of their homes, they're daily wage earners, there's inflation, there's lack of access of health services. The least you can do is make that healthcare services easily accessible and readily available to them. So by the use of this signpost intervention, people can give it a missed call. So we have done that with the vulnerable population. They give us a missed call, we call them back, and we seek information if they're not well. Even if they're asking information that their card has expired, which UN body or which government department they need to reach out. So we are making comprehensive services available, not only in terms of COVID, but in terms of journal, psychological first aid at this point as well. And then again, we have actually used mediums which are acceptable in terms of building trust, vouching on the trust which is already there, and kind of combating misinformation that is not only there in terms of accessing healthcare services because of COVID, but is also there in terms of COVID itself. We've seen with multiple waves at this point of Pakistan, we're into, unfortunately, the third wave itself. So we've used mediums like TV, we've used mediums like radio, we've used mediums, robocalls, TP tabs. We've done the rapid need assessments in multiple areas. We actually did a coordinated gap analysis across 44 districts. So the idea was to have that information in terms of community outreach, in terms of their perception of the situation and how they want to reach out for those services. And we have actually worked on that. And a lot, as I shared earlier, a lot of our ambassadors during this, in terms of community outreach, have been individuals who were part of the vulnerable groups over the past 7 and 8 years, and they've actually transformed their services into actions during the past 1 year as well. And last but not the least, I think one learning that I'd want to share that has kind of contributed to the factor of the trust is kind of introducing cash programming. So you give that individual the power as in to make that decision. It's easier for us to give out services. It's easier for us to tell them that this is good, this is bad, this is what you need to do, this is who you need to reach out. But by giving them that financial independence, be it for maybe I'd say less than $10 or maybe $15 or maybe 12,000 Pakistani rupees, you give them that, you empower them to make that decision in that given point of time of what is important to them, and then you complement that with the availability and the accessibility of these services. So I think I can go on as far as the trust element is concerned, but thank you so much for the opportunity, and I'm happy to answer any questions right now and thereafter as well. Thank you.
Thanks a lot, Dr. Alina. Maybe I would like to ask one other question to you. What are the possible consequences from the lack of trust within the community as well as between the community and external parties?
Omar, I think a valid question, one that we have been asking ourselves over the past 1 year. I pick up on the example for the COVID because I think that has actually changed my, what do you call that, the aspects and perception of the society as well. I can vouch for the fact that if your community did not cooperate for the fact that why social distancing is important, why wearing a mask is important, so that kind of applies to everyone in the world. That applies to people who are vulnerable, that applies to people who are not vulnerable. Imagine they trusting us that whatever we are telling them as practitioners, as specialists, as clinicians, is enough to safeguard their lives and that of their loved ones. That is why it is important. And I think that has been a game changer. If you look at countries, if you look at communities where they've been able to kind of control the transmission to an extent, it is because of the fact that when you tell people, people regard what you're telling them, they follow. They not follow in terms of you're dictating them. They follow that they trust you with that information. They trust us for the fact that whatever we are telling them, it is important for them and their families. That is why I say that trust is embedded in the COVID response. I always tell people that COVID's response is not actually a medical response. As soon as we as a country program were able to embrace the fact that this is a behavioral response, the quicker you adapt yourself, understanding the behaviors of the others and kind of embed and make use of the aspects of trust, it has actually made remarkable changes in the long run. So I'd say we have more to learn, but then again, this is what we have seen in the past 1 year or so.
Thanks a lot, Dr. Alina, on your insightful points and sharing your experience as well with us. Now moving to our third speaker, the President of Mercy Malaysia, Professor Dr. Ahmed Faisal Muhammad Berdaus. Professor Faisal, how does trust play a role in your fieldwork, and can you provide a real-life examples?
Thank you, everyone. Thank you, Omar. Thank you, Melati. Thank you, Auckland University, the Center for Asia Pacific Refugee Studies, the Asia School of Business, and everyone involved for organizing this webinar and for inviting me. I'll be precise and as concise as possible. So with the matter of trust, again, thank you very much to Melati for that very good opening presentation. And thank you also to Alia from the International Rescue Committee for that insightful presentation on the situation in Pakistan. I'll just go straight to your question. How does trust play a role in our fieldwork? Well, without trust, there won't be any fieldwork. That's in a nutshell. Examples, I'll give you 4 just to start off with. We, of course, at Mercy Malaysia operate not only in Malaysia, but also elsewhere around the world. So in Afghanistan, where we operated from 2001 till last year, and we only stopped functioning in Afghanistan last year because of the lack of funding. During the 19 years we were there wasn't one occasion when we were attacked either by insurgents or by the international forces, the allied forces, if you like, or by forces aligned to the Afghan government. Our bases were our centers, our bases were always welcomed. Of course, we had visits from all sides, and we conducted ourselves fairly, I think, with everyone, so much so that some of the armed insurgent groups took pains to identify the Malaysian flag, if you know what I mean, because it appears on some of our vests, and in the end we decided not to have the Malaysian flag on some of the work vests because it looked very much like the American flag. So just to avoid any confusion, but they actually were very good and actually took pains to identify us. That was in Afghanistan. In Syria, we actually up till about 3 years ago still conducted active cross-border operations across into Syria, especially from Turkey, and we're still active there at the moment in northern Syria. Again, we have the trust of all parties to cross, even at the time when ISIS was actually present. Of course, they are no longer there, and again, how do we build this trust? We build it by being consistent in our approach and by being fair. In Malaysia, one of the things that we do in Malaysia is we maintain our profile at a very reasonable level, not too much, not too little, because it is, after all, our home country. Sometimes we find that too much of a profile can be damaging as well. But on the other hand, too little, and if people don't know what you're doing, can also be detrimental. So just about enough publicity, just about enough profiling, and that will gain us the trust of those who are in the corridors of power. On the other hand, with those whom we help and aid, whether they be Malaysian or refugees, we actually are consistent in our work again, and we are also consistent in our advocacy messaging. In Myanmar and Bangladesh, the 2 other countries where the Rohingya are facing grave difficulties, we are about the only organization apart from MSF, I think, that is operating in all 3 countries with regards to the Rohingya refugees in particular. We are operational in Rakhine until today. We are one of the few organizations who have full registration and the ability to move around in Rakhine State, even at this moment of chaos and martial law in Myanmar. We, of course, are still operating in Cox's Bazar through partners now that COVID is on board. Before that, we were there physically ourselves. And of course, we are with the Rohingya refugees in Malaysia. So in all these 3 theaters, if you like, again, we are consistent in our approach. We give aid where the aid is needed, not where it is not. and we maintain engagement with all the governments and the authoritative bodies, if you like, either be it in Myanmar, in Bangladesh, or in Malaysia. Of course, in Myanmar, it's a much more complex. There are different levels at the local level, at state level, and then of course at national level. And even when the previous government was in power still, for example, we still had to engage the military, even though they were officially behind the scenes. This was always going to be the case. With the refugees in Bangladesh and with the displaced people in Rakhine State in Myanmar, we maintained a professional but empathetic relationship, and we made sure that they understood that we were there for them. But on the other hand, that also that we had limitations. We never promised the sky. The same goes with our work in Malaysia as well. When it comes to refugees, it is very easy sometimes for operational agencies and for humanitarians to actually want to do everything. It's very important for humanitarians, I think, to from the very outset, to understand our limits and limitations and not go beyond that if possible. Because sometimes if you promise and you cannot deliver, you not only disappoint people, but you lose trust. Now, going on to the other question that I've been put forward with, which is the fact that trust is a two-way issue, and that as a key intermediary between government and marginalized populations like refugees, what approaches have we, Mercy Malaysia, taken in building trust between all these parties? Now I will go specifically a little bit more into the refugee situation in Malaysia. Of course, I can extrapolate this to our other work theaters, either in Syria, in Myanmar, and Bangladesh as well, but I don't think we have time today. So we focus on Malaysia, and I think Melati has given the broad picture. And yes, there are 190,000 refugees in Malaysia, of which more than half of whom are Rohingya, or rather from Myanmar, and the majority of those are Rohingya refugees. And those are the registered ones with UNHCR, by the way. There are others who are not registered or in the process of. And in Malaysia, there are a few approaches that we take that is perhaps a bit more peculiar to Malaysia, and on top of the usual steps that we take anywhere, whether it be in Palestine, in Gaza, in the occupied territories of the West Bank, in Bangladesh, as I said, in Cox's Bazar, or in Myanmar, in Rakhine, or in more natural disaster situations in Indonesia or non-conflict areas of the Philippines. In all these areas, of course, there are some standard approaches that all humanitarian organizations take. But in Malaysia, there will be some added viewpoints, if you like. So, first of all, of course, as a humanitarian organization, we stick to humanitarian principles. I think that is first and foremost. And on top of that, like I said earlier, we show, and not just by saying, but by doing, that we do adhere to the humanitarian principles, and we are consistent when we do so. We don't, use the humanitarian principles just when it's nice to do so, or when it fits purpose only. Of course, sometimes things can get difficult, and even in Malaysia, although Malaysia is, when compared to many other Asian countries, perhaps is in the upper middle income bracket globally, as well as perhaps being viewed as having a more developed political and economic system compared to some other countries. On the other hand, there are also aspects of Malaysia which are still very much still stuck where it was 20, 30, 40, even 50 years ago. Yeah? Some traditions, the very feudal outlook of some parts of society, for example. So we have to take all that into account, and having an understanding of where you work is the other approach we take. And in Malaysia, although it's our home country, we do not underestimate the fact that although we're a Malaysian-born organization, we have to tread carefully, and even more carefully, because we're a Malaysian organization. And this is perhaps one of the debates when it comes to localization, globally. And I remember and this even back to where it was 5-6 years ago when the debate on localization began to take its form, and I was then chair of ICVA. Even globally, the argument has always been whether or not local is always best. Yeah, and remember, this was even before the pandemic. So, so sticking to the humanitarian principles, understanding your local scenario, and of course that includes politics. Yeah, anywhere we go, in Myanmar, Bangladesh, Palestine, Indonesia, Philippines, Mindanao, which is a separate part of the Philippines, if you like, where culture, politics, economics are concerned with the rest of the Philippines. But even like I said, in our own home country, which is Malaysia, and although we take a very deep study of politics in Malaysia, we of course, one of the strengths that Mercy Malaysia has had over the last 21, 22 years now of our being is that we have remained strictly apolitical in Malaysia, knowing very well that the political scenario in Malaysia is still developing and very much evolving, if you like, rather than having reached a matured stage. We are not yet at a stage in Malaysia where differences of opinion can sometimes or is always accepted. Yeah, so we are very aware of that, and so that's another thing that we do. That's the other approach that we take. We of course engage. When I say engage, we engage positively and constructively. First and foremost, of course, with the beneficiary community, and we focus on the refugees, definitely with them above even what we do with the local marginalized population. And with them, of course, we've built an understanding going back all the way back to 2004, 2005. And this means that we have a very deep and long-standing relationship with the refugee community, even before the numbers were as it is now. And as their numbers grew, so have our understanding, and so have their understanding of us. And part of the engagement, of course, has evolved around aid, be it food or shelter or our biggest area of strength, which is health and medical services. On the other hand, we've also not shied away in the last few years of actually engaging in advocacy for them, especially when the climate was a bit more permissible, if you like, about 3-4 years ago when a new government took over about 3 years ago. And we've conducted, for example, a few humanitarian labs, which have come up with some very good propositions and have been taken up by both the government and UNHCR. We also engage UNHCR, of course, as a partner, not just globally, but in Malaysia. And we don't forget, we have never forgotten to engage the government agencies. Of course, there are different levels of engagement, and we do that all the time on a consistent and constant manner. And again, with some agencies it's easier, with some agencies it's a bit more difficult. With some agencies, some things can be said publicly. With some agencies, you can't. Yeah, as things have to be done behind the scenes. Because we're an operational agency, we understand that some of the hard advocacy we leave to other people to do. On the other hand, we also understand that we carry a lot of weight, sometimes a lot more weight than some of the people who do some of the hard advocacy. And so we have to pick and choose the timing and the instance when we want to do that hard advocacy ourselves. We have to pick the topic usually that we can actually ride on. So we engage, for example, the political setup as well. We are part of the all-parliamentary caucus on access to healthcare for refugees and migrants, and we actively engage there. And Lilian Getanya, who's lead in Malaysia and regionally, has been instrumental in both setting and coordinating that. And we have also engaged the local NGO fora, if you like. And one of the examples of which is that in the area of health and medical services, we could have easily actually gotten the entire financing and funding, which was made available by the state of Qatar for health services in Malaysia for refugees, if we had really lobbied and pitched for it. But we understood that also that for it to work better and for it to have better reception, not just for the sake of the refugees, but also for the Malaysian public to receive it better, it's best that we do it with partners. And we told the Qataris from the very beginning that while we had the capacity to do it ourselves on our own, we would also like to engage our NGO colleagues, and for that we had two other Malaysian NGOs, Imaret and Malaysia Relief Agency, join us in sort of a consortium whereby now we have 5 clinics throughout the Peninsula Malaysia, providing health services to refugees. And this is in fact quietly appreciated by the government, because again, they actually acknowledge the fact that they can't provide all the health services needed by the refugees, and it helps that there are agencies like ourselves who want to do it. There is that little bit, of course, that we have to do, which is, and this is a very important point, I think, when you're working with refugees in any country, that you have to take into account the perception and the feeling of local governments as well as local communities. It's not unusual for anywhere in the world for this to happen, that xenophobia and refugee phobia or migrant phobia comes about. If you once refugees are in a particular country, not just Malaysia, anywhere else, and not just in the Asia Pacific, even in Europe, even in the Middle East, yeah, you would think that for some of the Middle Eastern countries, that because most of the refugees are of the same kin and religion, that there would be no problems. There will be, especially if attention is being paid more to the refugee community than to the local community, who may not be so well off anyway. So in Malaysia, especially, but also elsewhere that we work, Muslim Malaysia takes pains when we work with refugees to ensure that we also don't neglect the local population, especially the poor, either urban or rural. We make sure that we still continuously conduct programs and operations for local populations, not just for refugees. So in the clinics that are funded by Qatar, for example, while the focus is on refugees, we announce it that we do not turn away local Malaysians who come to the clinic as well. Especially if they come from the B40 group, they will be given or accorded the same amount of leeway as far as the fees are concerned, etc. And we make sure that's known. So that's key to gaining the trust of the local community. It's not enough to just gain the trust of the refugees, because if you do that in a not so smart way and gain the ire and the anger of the local community, what can happen is sometimes a backlash, and that backlash doesn't help your relationship with the refugees anyway. And one particular area of connectivity that is important when we do this work is how we work with international partners, be the international NGOs like MSF, for example, who have a presence in Malaysia, particularly for refugees and the stateless, as well as with UN agencies. So we have to be smart in how we do this. We've partnered MSF, for example, in both operations as well as in advocacy. We even conducted a symposium about 2 years ago. I think Melati was invited to speak as well, whereby we focused on one of the directives that the Ministry of Health had, whereby hospitals and healthcare providers were instructed to actually report migrants or refugees who come to their clinics or facilities. That was just an example. And with the UN, we were early advocates for having a humanitarian country team in Malaysia, although Malaysia is not a country which generally is in humanitarian crisis. And part of the reason is because then we will have a channel whereby international NGOs especially can connect with the UN system and have it, shall we say, together sometimes, and sometimes by ourselves without the government necessarily being heavily involved, because sometimes you do need to have that connection and openly. Sometimes you need to have that connection just outside of the formal government purview, so that some things can be discussed. Going forward, and the last bit that's been asked of me is the concern about vaccination in Malaysia. Well, before this vaccination crisis, if you like, came about for Malaysia, we're having a crisis now because we're having an upsurge, as Melati said, of COVID-19 again, for many reasons, which we don't have time for today. And on top of that, we have a slowing down of what was supposed to be a very well constructed and well planned national immunization program for COVID-19. And part of it, of course, is because of lack of supply. What's happened in India, what's happened elsewhere, and the vaccine nationalization in wealthy countries have, of course, impacted Malaysia as well. And going forward, we have to look at this with open eyes. And we had actually an example last year from which to draw on, and it was about testing. At that time, the priority was testing, and there was a big commotion when Mercy Malaysia started to test refugees, for COVID-19. Again, the same principles we applied in engaging, we applied when we were testing. We made sure that we didn't test only refugees. We tested Malaysians as well. One of our testing programs even got into a now infamous Al Jazeera documentary, which tried to discredit the government on another angle. And again, that was a challenge for us, but we managed, and all sides maintain their trust in us. I guess it's a delicate balancing act, if you know what I'm getting at. So with vaccination in Malaysia going forward, we've already laid the groundwork for this. We know that to give. We've been consistent in our advocacy on this. Whenever I speak, or any of our senior leadership team speaks to the media, etc., we always say that vaccination should be for all. But we stress the point that the only reason we are saying that is also because it's the only thing that makes sense. That there is no sense in excluding, for example, the migrant worker population or the refugee population from vaccination if Malaysia wants to get out of the COVID-19 pandemic, because otherwise you'll have a reservoir of people who act as a reservoir for the virus, and it just doesn't make sense. And so we use that scientific argument, if you like, to bolster our advocacy that everyone should be vaccinated. Now, coming back, we again make sure we've engaged Ministry of Health, we've engaged the COVID-19 vaccination task force under the Access to Vaccines Committee at the national level. We volunteer to assist the Ministry of Health as well as the COVID-19 vaccination task force in vaccination programs for Malaysians. So that then ourselves, our partners, our other NGO colleagues, as well as UNHCR can also then proceed with vaccinating the refugees without too much interference. Now, with regards to the refugees themselves, when it comes to vaccination, of course, that's another challenge by itself. There are three challenges there. Number one is whether they will come for vaccination or not, because as Melati has just pointed out, and I don't have time to go through all that again, is that they lost a bit of trust with the government last year because some of them were heavy-handedly handled, and some were even detained, and some even deported, whereas they were initially promised that there would be no action taken if they came forward for testing. So there needs to be now a re-engagement, and we have trying to assure them that again, that if they come forward, we will make sure that if in our program at least, that there will be no reporting of them to the authorities for any other reason. Now, we've also engaged the authorities quietly to again ask them that if we could go ahead with vaccination without interference of the refugees. So it works both ways. Yeah. Number two challenge with trust with regards to vaccination, of course, is the usual trust issue with regards to vaccination anywhere, especially in among communities who may not have trust in vaccination per se, not just COVID-19 vaccination. And so this is an ongoing challenge, not just with the Rohingya refugees in Malaysia, but also with large segments of the Malaysian community. But again, it's not unique to Malaysia, it's everywhere in the world, including in the States. Yeah, perhaps not so much in the UK and Australia, as far as I can see, but definitely in the US, there are also large pockets of people there who don't want to be vaccinated, and the same goes in Malaysia. So we will have to send that message. We're involved with the National Disaster Management Agency at the moment in a nationwide campaign to encourage vaccination, among others. And last but not least, of course, is the trust factor when it comes to efficacy and also the usefulness of the national immunization program. Again, I don't have time to go into it, but there has been a lot of loss of trust in Malaysia's political scene over the last 1.5 years for many reasons again. One of the effects of that loss of trust has also been a side effect, if you like, that anything that the government does is viewed skeptically by some, and this again cuts across the society, not just refugees. The refugees, of course, listen to Malaysians, and sometimes they also then say, "What if why should we go when even the Malaysians here are saying that they will not go because they don't trust the government?" So we will have to again engage and tell them, look, the vaccine program has got nothing to do with the other issues, and that please come forward, and this is for your own good and for your community's good, and that it will protect you and your loved ones. So I think I'll stop there. Thank you very much.
Thank you so much, Professor Faisal. It's always delightful to hear about the amazing work that is done by Mercy Malaysia. I myself have attended more than 5 meetings that Professor Faisal have spoke in, and I always gain more knowledge and understand more about the amazing work they have done. Now moving to our session of question and answer, we have one question that is directed to both Malaysia and Pakistan. In this research, what method was used to trace and to track information flow in the refugees community? Were you reliant of information who were allies of the refugee or also the refugee themselves? Maybe if we can have Dr. Melati speaks first about Malaysia, and then we have Dr. Alina speaks about the condition in Pakistan.
Yes, thank you for that question. So the difficult thing I find doing research of the refugee community, but the thing that I think makes it very interesting is that it is very difficult to be able to trace the flow of information. So what do I mean by this? So in social sciences in general, I think there's a sense in which you can't really explore the truth per se, but rather reports on the truth. But for a hidden community like refugees, it's actually really hard to also verify any amount of truthiness. So if you think about in Malaysia, we don't have very much administrative data available. And this is a community that's not even on the books, right? So in order to sort of, verify things, asking for documents perhaps that say, verify how much you make or who's actually employing you, I'm not actually able to do very much of that. So what I do rely on, however, is sort of triangulation within a community itself. So the sampling done for the study was sort of twofold. So it was snowball sampling from multiple points of injection into the network. So we had community leaders, we had community leaders, refugee community leaders who were basically allies of local NGOs. So we got their names and their contacts from locals who had interfaced a lot with the refugee community. So you sort of have the elites, I guess, the leaders of the community, but we also tried very hard and were able to find sort of average members of the community. So people who maybe don't have leadership roles, people who were not in charge of distributing aid, people who are instead on the receiving part of aid and the sort of the receiving part of information, right? Not the creators, but rather the consumers of that kind of stuff. So sampling was done very much in acknowledging basically the difficulty in verifying anything, and also the power dynamics. So the paper talks a bit more about, power dynamics between Malaysians and community leaders and stuff like that. But to some extent, we did try and be comprehensive with trying to get the information, with the caveat, of course, that we are never able to observe the truth, just reports on the truth. So I guess that's all I'm going to say. I guess to you, Dr. Alina.
Thank you so much, Dr. Melati. I think you've rightly pointed out that this is not exactly a trick question, but not an easy thing to do. But then again, as a few of you might remember that I mentioned the signpost intervention, which actually provided the IRC with an opportunity to have a two-way set of communication. And the idea was to kind of target the vulnerable groups, and especially the refugees the most, using this intervention. So we did an information needs assessment for this particular intervention, and our methodology was to adapting a longitudinal and using a mixed method approach. So what we did was that our initial stage, that is for our primary data collection, we had 3 major metropolitan cities which have seen population or embedded population with that of refugees. So half of them had a mix of semi-urban population, and the other half of it had these the urban population and the rural population as well. And then we made sure that we have a stratified random sampling method in place, targeting the specific vulnerable groups, including that of refugees. I know it sounds good on the paper, and when you kind of triangulate with things on ground, but this is the best that we can do. Instead of not having any set of information, this is what we use. And then again, we had key informant interviews, making sure that we have those voices heard and kind of integrated in our intervention. And in this particular needs assessment as well, there were focus group discussion as well. I'm happy to share the white paper and also this information needs assessment. And I also mentioned earlier that we did a very detailed coordinated gap analysis in 44 districts, which was actually done with the government, the NCHD department, and we had over 16,000 households. So this was one of the prime exercises that was actually done in terms of protection monitoring across sub-indicators, be it for education, health, livelihood, and that is also available. It is also published documents. I am happy to share that the findings of it. So these are the indicators that I can think of as of right now that we made use of in our interventions and in our research component as well.
Thanks a lot, Dr. Alina, on this amazing point. We have, I think that's the last question that we are going to take for today, from Sue Ann Lee. How do we avoid survey research fatigue that we are seeing now with the stress of COVID-19 lockdown, particularly in refugee communities? How can data collection be done ethically?
I guess I'll take this. So one thing that I think everybody who works in this field is very aware of is the research fatigue in particular, but also on top of that, another issue that we have faced is this idea of compensation for time, which I think is also kind of part of the ethical issues surrounding research of vulnerable populations. So in terms of the sort of ethics of it, first of all, and I think Dr. Faisal had mentioned this before with the infamous Al Jazeera documentary here, we take very strong steps to protecting identities. So if you email me, I'll send you the draft paper. You will basically see nothing that is able to identify any of the individuals we speak about. And my team takes extra steps to protect any information we do have. So, in terms of storage, in terms of anonymizing at point of transcription, et cetera. So that's sort of the first step in all of this, is ensuring that if somebody comes to me and wants detailed information, I won't be able to tell them because I don't have it. That's the first thing. The second thing with research fatigue. So one thing that I always do and sort of train my team members to do is really to not be pushy. So we typically send out maybe one request for interview or for survey, and then we send a reminder, and if we don't get a response, we just let it go. And I have sort of, very aware of this, also offer, and this may be something that economists do and not other people, but we also offer, small compensations to speak to us, because we understand ethically we can't ask you for, it's a two-way street, trust, so we can't ask you for things and not compensate you, because you may be working during that time, or you may be doing something, much better than answering my survey questions or my interview questions. So we try to ensure that we do compensate you for whatever time you spend with us. Which again is sort of a way that we also try to build trust. And don't bother people too much also, because it's not really, it's the agency, sort of the ability to say no should not lie with the researcher, it should lie with the community that you're trying to research. So that's I guess that would be my three main points: is compensate researchers, do not bug them, and ensure confidentiality, because if you think about it, if you can't even do that, there's no point in them speaking to you. That's it, Omar.
Thanks a lot, Dr. Melati. I will now attempt summarize this very rich and insightful discussion, but please allow me to highlight a few key takeaway points. Trust is complex and layered. It's influenced by perceptions, beliefs, lived experience, including trauma, and the ways in which people can or cannot access services. Trust also fragile. It can be easily lost, especially among marginalized communities, such as a refugee who lack documentation and face so many barriers and accessing services. The importance of making services available for vulnerable communities, training frontliner, and mobilizing diverse stakeholders at the community level to gain trust. Without a trust, it will be impossible to work with the communities. Trust is built by being consistent, maintaining engagement with all relevant stakeholders, and by not over-promising. The importance of gaining trust of the local communities as well as refugee communities to ensure social cohesion. Ladies and gentlemen, we have come to the end of our webinar. Please join me in thanking our brilliant speakers, Dr. Melati, Dr. Alina, Dr. Faisal, and our organizers as well, Asia Pacific Refugee Rights Network, as well as Center for Asia Pacific Refugees Studies, and Asia Pacific Network of Refugee, and the Asia School of Business. Thanks a lot for your attendance.